Okay, welcome back to the deep dive. Today, we are diving into something that, well, it shows up time and time again, especially when you're getting ready for exams like the MSRA.
Hmm.
We're talking erythema nodosum.
Yeah.
Think of this as us cracking open your revision material together and pulling out the absolute core stuff you need.
Exactly. The mission today is simple. Get straight to the essentials of erythema nodosum. We'll grab the key facts from the material, put them together, and really highlight why this is so high yield for revision. Let's make it stick.
All right, so let's paint a picture. A young woman maybe walks into your clinic. She's got these really tender, kind of red, lumpy spots on her shins. Painful, maybe a bit warm. What are we actually looking at here? What is erythema nodosum?
Good place to start. Fundamentally, erythema nodosum is an inflammatory condition. It affects the skin, but not just the surface layer. It's specifically inflammation of the subcutaneous fat, that layer right underneath.
Wait, the fatty bit.
Exactly. And clinically, it shows up as those classic tender red nodules you mentioned. Overwhelmingly, they're on the shins.
So it's deeper than just a surface rash.
Precisely. And critically, the thinking is that this is usually a hypersensitivity reaction. It's not typically the main problem itself.
Okay.
It's often the skin acting like a signpost, yeah.
Yeah.
A dermatological flag telling you something else is going on systemically, often an infection or some kind of systemic disease.
Mm-hmm.
These nodules, they're usually about 2 to 6 centimeters, mostly shins, but sometimes forearms or thighs too. And importantly, they tend to resolve on their own, usually in about 6 weeks, and crucially, without leaving scars.
Okay, so if it's the body reacting, maybe overreacting, what sort of things trigger it? What should pop into your head straight away when you see this?
Right, this is the detective work part, and it's vital for the exam. The common triggers you need to have on your radar are, first, infections. Strep is a really big one, especially after a recent sore throat.
Strep throat, okay.
Yeah. Tuberculosis is another classic link. Brucellosis, too. Then there are systemic diseases. Sarcoidosis, very strongly associated with EN.
Right, I remember that one.
Inflammatory bowel disease, so Crohn's and UC. And Behçet's disease.
Okay.
And then other significant causes. Malignancy, particularly lymphoma, can sometimes present this way. Medications are common culprits too. Think penicillins, sulfonamides, and the oral contraceptive pill.
Wow.
And finally, don't forget pregnancy itself can trigger it.
That's a really broad list, isn't it? From, like, bacteria hiding somewhere to your own immune system acting up, or even just drugs or hormones?
It really is. And finding that underlying cause is, well, it's key to managing the patient properly. The material really stresses that finding an infection underneath is common. There are rarer links too, like EBV, Hep B, Hep C, HIV, but definitely focus on that main list for revision.
Got it. So, given that big list of potential causes, are there specific people who are, more likely to get erythema nodosum? Any key risk factors?
Yeah, definitely. The material points to a few things. You should think about people with a history of those specific infections we just talked about.
Makes sense.
Also, people with existing autoimmune diseases, again, fits with the systemic links. And significantly, female gender. It's much more common in adult women.
Ah, okay.
And obviously, recent use of those specific medications we listed earlier.
So if an exam question mentions a young woman, maybe she has Crohn's and she comes in with these leg lumps, erythema nodosum should be right near the top of your list.
Absolutely. Peak age is usually between 20 and 40, especially women. The material doesn't really specify why female gender is a risk factor. Could be hormonal, could be autoimmune links, but just knowing that association is really important for exams.
Okay, let's dig a bit deeper into how this actually happens. You said it's a hypersensitivity reaction. Can you break down the pathophysiology a bit more? How does this reaction turn into painful lumps in the fat?
Okay, so technically it's described as a type 5e hypersensitivity reaction. You can think of that as a delayed immune response mediated by cells.
Delayed, right. Not immediate.
Exactly, not like an instant allergy. It gets triggered when the body is exposed to an antigen, something it sees as foreign, maybe from an infection, or sometimes even a self-antigen in autoimmune conditions. This exposure kicks off a process involving immune complexes and inflammatory cells.
Wow.
And for reasons we don't fully understand, this whole inflammatory response specifically targets the small blood vessels and connective tissue within the subcutaneous fat. That's what causes the characteristic nodular inflammation. It's like the immune system gets sort of stuck on repeat, overreacting right there in the fat layer.
That helps picture it, the immune system getting fixated on the fat. Now, differential diagnosis. Super important. You see these tender red lumps on the legs. EN is likely, but what else could it be? What else needs to be on your mind?
Absolutely critical for exams. You have to think broader than just EN when you see painful skin nodules. The material lists several key differentials. First, just think generally. Other kinds of panniculitis, inflammation of the fat. Vasculitis, inflammation of blood vessels. Or even something like cellulitis, a bacterial skin infection.
Right.
Then, more specific conditions to consider. Erysipelas, which is a more superficial infection but can look red and angry. Erythema Nodosum, that's a specific type of nodular vasculitis, often linked to TB, actually.
Ah,
Simple insect bites can sometimes cause big local reactions. Acute urticaria or hives, though they're usually itchy and come and go faster. Familial Mediterranean fever, that's a genetic inflammatory thing. Scleroderma.
Right.
Other types of vasculitis, like polyarteritis nodosa. Rheumatoid nodules, though they're usually firmer, near joints, and often painless. And superficial thrombophlebitis, inflamed vein near the surface, can feel like a tender cord.
That's quite a list to keep in mind.
It is. But here's the really helpful bit from the material for differentiating. Look for atypical features. If the rash lasts longer than, say, 8 weeks, if the lesions ulcerate, or if they're not primarily on the legs, those are red flags.
Ulceration is a big one then.
Huge. If you see those atypical signs, you need to strongly question if it's really typical EN and seriously consider those other diagnoses, especially things like vasculitis or certain infections.
Okay, let's try a quick scenario then. Listener, imagine this. 45-year-old man, tender red lumps on his shins. Looks like what we've described. But when you see him again, some lumps are starting to break down. They're ulcerating. Based on what we just said, what should immediately spring to mind? Which differentials jump up the list?
Yeah, that ulceration is the absolute key. Typical EN just doesn't do that. So seeing ulcers completely shifts your thinking. You should be strongly considering things where ulceration is expected. Erythema Nodosum, that nodular vasculitis, is way up there. Other forms of vasculitis too, or maybe a nasty infection causing tissue breakdown, that single feature changes everything.
That's a brilliant distinction to lock away. Okay, what about frequency? How often might we actually encounter this? What's the epidemiology look like?
Yeah, the incidence data suggests in the UK it's around 2 to 5 cases per 100,000 people per year. So not super common, but definitely not rare either.
Right.
And as we said, most common in young adults, peak age 20, 40, and definitely more frequent in females. So you need to be able to recognize it when it does walk through the door, especially given all those underlying links.
Okay, let's really nail the clinical picture. We know about the tender nodules on the shins. What else might the patient complain about? What else might you find? Give us the full rundown.
Okay, so core feature. Tender red nodules, usually symmetrical, on the front of the lower legs, the shins. First week, they feel tense, firm, quite painful. And remember, typically they do not break down or ulcerate.
No puss, no ulcers. Got it.
Exactly. Individual lumps might last about 2 weeks, but new ones can keep popping up for maybe 6 weeks total, so the whole episode can drag on a bit.
Right.
But beyond the skin, patients often get systemic symptoms. Sometimes these actually start a week or two before the skin stuff appears. Things like just feeling generally unwell, malaise, fatigue, maybe a bit of a fever. They might also have aching legs and swollen ankles. And that swelling can hang around for weeks, even after the nodules fade. And a really key associated symptom is arthralgia. Joint pain, super common with EN.
Joint pain plus skin lumps. Sounds like it could get mixed up with other things easily.
It could, but the details help. The arthralgia usually hits the ankles, knees, and wrists. Patients might complain about morning stiffness, which can actually last for months, maybe up to 6 months. But UT, and this is vital, there's no actual joint destruction. And tests like rheumatoid factor are negative.
Okay. That helps rule out RA then.
Exactly. It helps differentiate. And as the skin lesions heal, they change color, just like a bruise does red, then bluey purple, then eventually kind of yellowy brown as they fade.
Okay, mini case number 2 then. You see a 25-year-old woman, bilateral tender, reddish-purple lumps on her shins. She also says her ankles have been aching, feels generally wiped out for the last week or two. Based purely on those classic features, what's screaming out at you?
Yeah, that's pretty much textbook Erythema Nodosum. Tender, evolving nodules on the shins, systemic symptoms like malaise, prominent joint pain, especially ankles in a young woman. Those are the absolute classic signs you need to spot instantly.
Got it. Recognize the pattern. So once you suspect EN, the next job is figuring out why. What investigations should you be thinking about to hunt down that underlying cause?
Right. The diagnosis of EN itself is mostly clinical based on what you see and feel. The investigations are all geared towards finding the trigger. So the workup should include things like a throat swab for strep is standard. Although an ASO titer, the anti-streptolysin O test, is often more useful as it can show evidence of a recent strep infection, even if the swab is now negative.
Okay, ASO titer. Good tip.
Yeah. Then routine bloods. FBC, ESR, CRP. The inflammatory markers ESR and COP are usually high.
Makes sense.
If they have any gut symptoms, maybe stool examination for bugs or blood cultures. To screen for sarcoidosis, you check serum calcium and ACE levels. ACE can be raised in sarco.
Right, ACE for sarcoidosis.
A chest x-ray is pretty essential too. You're looking for signs of TB or sarcoidosis, which often show up in the lungs. Intradermal skin tests, like a MAN2 or an IGRA blood test, are specifically for excluding TB. Depending on where you are, maybe tests for things like coccidioidomycosis.
Okay.
And lastly, an excisional biopsy of a nodule. Usually not needed for typical EN, but it's there for cases where you're just not sure, back to those atypical features. If you really need to rule out vasculitis or something else definitively, a biopsy is the way.
So the tests aren't really to confirm the EN itself, more to systematically tick off the most likely culprits causing it.
Exactly that. It's cause finding.
Right. So once you've landed on Erythema Nodosum, maybe you've found the reason, maybe not yet.
Yeah.
How do you actually manage it? What's the treatment plan?
So the management is kind of two-pronged. You manage the symptoms of the EN itself, and if you find an underlying cause, you treat that. For symptomatic relief, which is often all that's required if it's, say, post-strep and self-limiting, simple measures work quite well. We're talking cool compresses, bed rest with the feet up to help the swelling and pain, and basic pain relief. The material specifically mentions NSAIDs, like ibuprofen, and also colchicine can be quite useful for the pain and inflammation.
NSAIDs and colchicine.
Yeah. And then, crucially, if you do find an underlying cause like active strep, or maybe an IBD flare is identified, then treating that specific condition properly is paramount. Treating the root cause will help the EN clear up.
What about steroids? They seem to get used for loads of inflammatory things.
Yeah, this is a really key warning. Use steroids very cautiously, and absolutely only after you've ruled out infection.
Why is that?
Because if the EN is being triggered by an underlying infection like TB or even strep, and you give steroids, you can dampen the immune response needed to fight it. You could actually make the infection much worse.
Oh, right. Bad idea.
Very bad idea. So, hold off on steroids unless you're confident infection isn't the driver. For really stubborn or severe cases, more specialized treatments might be needed, things like potassium iodide, oral steroids, again, with extreme caution. Maybe certain antibiotics like tetracyclines or macrolides, sometimes even biologic drugs. But for those complex cases, the advice is definitely consult secondary care. You want to be absolutely certain you haven't missed something serious before escalating therapy.
That makes total sense. Don't suppress the signal if you might be missing the fire. Okay, what's the usual outcome? What can patients expect long-term?
Generally, the prognosis is pretty good, which is reassuring for patients. It's typically self-limiting. It resolves on its own, usually within weeks, maybe a few months.
Yep.
Of course, the overall outlook depends a bit on the underlying cause. If it's post-viral, it resolves quickly. If it's linked to something chronic, like IBD, then managing the EN is part of managing the bigger picture. But importantly, the material states chronic or recurrent EN is rare, and the lesions consistently heal without leaving any scars or thinning of the skin.
That's good news. No lasting marks from the lumps themselves. Are there any potential complications, even if it usually gets better on its own?
Complications are definitely rare, but worth knowing. The material mentions ulceration, which, again, is really atypical for EN and should make you rethink the diagnosis.
Right, the red flag.
Exactly. Secondary infection of the skin lesions could happen, but it's uncommon. And occasionally, patients might have persistent or recurrent symptoms. But really, the main way to prevent even these rare issues ties back to everything else. Find and manage that underlying cause promptly and properly. Deal with the trigger, and the EN usually settles without any trouble.
Perfect. So to wrap up this high-yield deep dive for MSRA prep, the absolute core message for erythema nodosum is you see those tender red nodules almost always on the shins. They signal an inflammatory reaction. And your main job, the diagnostic hunt for that underlying trigger infection, systemic disease, meds, or pregnancy.
Couldn't say it better. Spotting the classic picture is step one. Step two is remembering this is usually a reaction, not the whole story, and knowing how to systematically investigate those potential causes. It really tests your knowledge across different areas: skin, rheum, infectious disease, general medicine, which is why it's such a high yield topic. And remembering those atypical features and key differentials is crucial for nailing the trickier questions.
Fantastic. Hopefully that's pulled out the really key bits about erythema nodosum for your revision. Remember, pattern recognition, then look deeper. For more free MSRA revision resources, you can visit freemsra.com. And for the full premium revision toolkit, head over to passthemsra.com.